I present a case report of two sisters with the transverse bilateral upper and lower limb deficiencies. The sisters were born from the same parents. While environmental etiologies cannot be ruled out, the similarity of their phenotypic manifestation could suggest an underlying genetic cause. So congenital limb deficiency is aplasia or hypoplasia of one or more limbs, one or more bones of the limbs, and it could be caused by medications like thalidomide, vascular compromise, biamnotic band, maternal diabetes, and maternal infections are some of the causes. After decades of disagreements on the nomenclature, in 1989, an international standard nomenclature was adopted that classified congenital limb deficiency into two broad categories as transverse limb deficiency and longitudinal limb deficiency. Longitudinal limb deficiency is a complete or partial absence of a specific bone. It could be radial, tibial, or fibular, while transverse limb deficiency is the common type of limb deficiency where there is a normal limb development until a certain point and beyond which no anatomical structure exists. And this presents as an isolated spontaneous abnormality as a result of arrest during limb bud development and early insult in apical ectodermal ridges. To my knowledge, transverse bilateral deficiency in both upper and lower limbs is not well described in different literatures, and this disorder can be an isolated or could be associated with other anomalies, and isolated transverse limb deficiency is the common type of limb deficiency occurring in 3 out of 10,000 live births. These are the methodologies I used for my case study. So the first case is a 6-year-old female presented with symmetrical distal, transverse, upper and lower limb deficiency with no other syndromic features or systemic manifestations. And she is capable of walking with the support of orthotics and has adapted to use her forearm to do several activities, not limited to eating and writing, as you can see. However, speed and certain activities that require fine motion are difficult to achieve. So this patient was first presented after the delivery of her younger sister, which I will present in case 2. So her medical records of antenatal follow-up are not available. However, developmental milestones have been made at the appropriate age, and the examinations of other systems like cardiovascular, respiratory, and abdomen is normal. When we come to the physical examination in the upper limbs, the patient has normal shoulder, elbow, and wrist function with transverse deficiency distal to the carpal bone. She also has normal spine, and in lower limbs, the patient has normal hip, knee, and ankle function with transverse deficiency distal to the hind foot. And this is the X-ray and the abdomen and the echocardiography are normal. This child has been reviewed to the pediatric orthopedic hospital. No surgical interventions planned, although there is surgical interventions like Crocombox procedure described in the literatures. It's felt that this will not have any additional functional benefit for this specific patient. So there is, and they could also be socially stigmatizing. So there is no surgical intervention planned. However, she is receiving assistance by specialist orthopedic surgeons who are working to improve walking and also providing adaptive equipment to facilitate self-care and feeding. The second case is a 5-month-old female. She is also born from the same parents and presented with similar clinical features as her sister. The antenatal follow-up of this patient was at Alert Hospital, where I work at, and she was delivered at 39 weeks of gestation by spontaneous vaginal delivery, weighing 2.5 kg, from a 26 years old primiparous mother. There was no any medical or obstetric complications. There was no any history of trauma to the abdomen. There was no any history of exposure to radiation, and there is no history of use of medications. So after the delivery, this baby was brought to the neonatal ICU to be evaluated for potential anomalies related to the condition, and it was discovered that her older sister also had the same condition. The physical examination of this patient is also similar to her older sister. There is no, with normal limbs other than transverse deficiency distal to the carpal bones and the hind foot. Examination of other systems, cardiovascular, respiratory, and abdomen is normal. This is the X-ray of the patient. The ultrasound examination during the pregnancy showed there was an anomaly, but the mother insisted to keep the baby. So the postnatal examination of the placenta was normal. Abdominal examination at birth of the abdomen and the cranium was normal. Genetic testing was not done. And at 5 months of age, we did an ultrasound of the abdomen, and it was unremarkable, but the echocardiography demonstrated a 1.2 millimeter PD shunting left to right. Otherwise, all the 4 valves looked structurally normal, with left ventricular ejection fraction of 72%, and the branched pulmonary arteries looked normal, and there was no coarctation. This child also has been reviewed at a specialist orthopedic surgeon, and there was no surgical intervention planned. However, when she begins to stand, the orthopedic surgeon will assist to improve balance and facilitate walking. Regarding the cardiac abnormality, it's expected to close spontaneously without any long-term consequences. The sisters were the only children born from these parents. However, the couples recently conceived a 3rd child who was terminated at 80 weeks and 4 days after intrauterine ultrasound indicated the presence of similar abnormality. In addition, the father has 2 sons from previous marriage, both of whom do not have any known anomaly. The parents are unaware of any family members affected in the same way, and they are unwilling to disclose any consanguinity. So when we think of the differential diagnosis similar to this patients, one of the differential diagnoses is amelia, like tetraamelia. It's also a transverse limb deficiency with no bony structures, but this amelia has mostly the absence is proximal segments of the humerus and the femur, and it's often associated with other anomalies like musculoskeletal, intestinal, and renal. So the other differential diagnosis is amelia. We all know Nick. He is one of the known motivational speakers. He also has this rare condition with upper and lower limb, with missing upper and lower limbs. But this specomelia is usually caused by taking drugs during pregnancy, and again, the lesion is more proximal. So this is one of the very similar cases from Brazil that we thought could be very similar to our cases. It's a rare disorder presenting with bilateral congenital amputation of the upper and lower limbs. And most individuals with this condition have bilateral deficiency beyond the distal epiphysis of the humerus and distal portion of the tibial diaphysis, with no other systemic manifestations. It was first described in 1929 in Brazil, and it's known as arthropodia. It's an autosomal recessive inheritance pattern with half of the family of the 12 children affected. The genetic analysis of arthropodia of the 5 families revealed a common mutation in C7F2, the human orthology of Mouse LMBR1 gene. This mutation was observed both at genomic DNA and mRNA level. This mutation led to premature stop codon producing transcript lacking exon 4. The sisters described in my case have different phenotypic presentation than described in the literature, arthropodia. In addition, the siblings have a lesion of extremities, distal, and they are meeting normal developmental milestones, while in arthropodia, the lesion is more proximal. As such, I could say this disorder is novel, and it's important to further investigate to identify which genes are involved, as it can enhance our understanding of molecular mechanism of the limb development in humans. Also, further genetic analysis of the family might explain how this condition emerged in the continent of Africa. When we come to the limitations, the first limitation is faced by the health professionals. As we are living in third world country, there are many limitations faced by the health professionals. One of the most significant limitation is unavailability of genetic testing like molecular and chromosomal tests. These are my personal limitations. I haven't really done research in the field of genetic study and the distribution pattern of this condition in different regions. Limitation and challenge faced by the individuals with this condition. One of the most significant challenge is mobility. They have difficulty walking and performing physical activities, which can limit their ability to participate in different sports, hobbies, and any type of recreational activities. And these patients especially need specialized equipment or modifications at home or at their workplace to accommodate their needs. This is specifically a challenge, especially in countries like mine. The other most significant challenge faced by this individuals is the social stigma and discrimination, and this usually lead to unfortunately there are many misunderstandings and stereotypes surrounding individuals with disabilities. They are mostly associated with being cursed, and this will lead to a feeling of isolation and exclusion. So I would say it's better to work on creating a more inclusive and accommodative environment for individuals with disabilities. And the other challenge faced by these individuals is a feeling of isolation, frustration, and low self-esteem, which will lead to anxiety and depression. So what did I do to address this? The first thing is I organized a team of volunteer doctors and developed a project. The first task was to fix them with an orthopedic surgeon working. He's from UK and he's working at NGO in our country, Cure Children's Hospital, and they are being managed as I described before. And the second is providing them with appropriate housing and monthly resources for their subsistency. And the third is we're working to establish a research and diagnostic center. So moving them from their current location was very critical because they were living in unpleasant environment where they share a small cell with several people, with having a very low standard of living, and they were facing a lot of discrimination and stigma because of their physical condition. And our team of doctors went to the higher organ of Addis Ababa city organization and asked for a plot of land. And after exhaustive and frustrating back and forth visits, we were able to get a plot of land and build accommodation, private accommodation for these children. And the older children just graduated from preschool. And we are also working to establish a research and diagnostic center to mitigate the challenges faced by the health professionals. These are the recommendations: advancing genetic testing and creating advocacy so they can have a supportive and safe environment. We have to work on the research and innovations. And in conclusion, these sisters were born from the same biological parents with transverse upper and lower limb deficiencies. And even though our initial diagnosis for these patients were arthropodia, their phenotypic manifestations are significantly different than all other patients with this condition. And this suggests that the genetic cause of their condition could be different. From the literature I reviewed, I don't came across as such case. So I suspect this could be a very rare genetic disorder that has not yet been described in the world, that it's important to conduct further research on this family to identify the genetic cause of the disease, which can also enhance our knowledge of limb development. And thank you.